Welcome to the Developmental Neurotoxicity in Vitro Battery Training Webinar Series. Part 3 of this course is on Quantitative in Vitro to in Vivo Extrapolation, or QIVIVE, consisting of 3 presentations. This is the first presentation, explaining you the concepts and providing some examples. My name is Jochem Louisse. I'm a scientific officer in the Pesticide Peer Review Unit of the European Food Safety Authority. A definition of QIVIVE was first provided in 2012 as the process of estimating the environmental exposures to a chemical that could produce target tissue exposures in humans, equivalent to those associated with effects in an in vitro toxicity test. For example, an EC50, a benchmark concentration, or an interaction threshold identified by a biologically based dose-response model for the toxicity pathway of concern. In 2025, the OECD released a document on QIVIVE in the series on testing and assessment of chemicals. The 3 presentations of part 3 of this webinar series are based on that document. The definition for QIVIVE used in the OECD document is the process of converting an in vitro concentration of interest into an equivalent in vivo exposure. The concept of QIVIVE is schematically depicted in this slide. To relate an in vitro exposure to an external in vivo exposure, one first needs to link the in vitro exposure to an internal exposure in vivo. And in the next step, the internal exposure in vivo needs then to be related to an external exposure in vivo. The current presentation will provide some considerations on this first step of relating the in vitro exposure to an internal exposure in vivo. To relate an internal exposure in vivo to an external exposure in vivo, typically so-called physiologically based kinetic modeling or PBK modeling is used. Presentation 2 will explain the concept of PBK modeling, and Presentation 3 provides detailed considerations on using PBK modeling for the QIVIVE of DNT IVB data. QIVIVE allows a quantitative interpretation of in vitro data for the hazard and risk assessment of chemicals. To do so, both a forward dosimetry and a reverse dosimetry approach can be used. When using a forward dosimetry approach, the starting point is an external in vivo exposure, which can be a given exposure estimate or a health-based guidance value. This defines the external exposure used as input in the PBK model to be translated into an estimated internal exposure in vivo. By comparing this predicted internal exposure metric to the in vitro exposure of interest, which can be a given effect concentration from an in vitro assay, the in vitro data can be contextualized with external exposure of interest. When using a reverse dosimetry approach, the starting point is the in vitro exposure of interest, so a given effect concentration from an in vitro assay. That is then related to an internal exposure in vivo, and subsequently the PBK model is used to estimate what the related external exposure in vivo would be. This estimated dose is typically called an external equivalent dose, and when considering the oral exposure route, this is an oral equivalent dose. So for contextualization of the in vitro finding, such an oral equivalent dose can be compared to a given exposure estimate or a health-based guidance value. It is important to note that QIVIVE is generally considered to translate an in vitro concentration to an in vivo external dose. By doing so, as explained in the previous slide, no translation is made of an in vitro response to an in vivo response. Therefore, an interpretation of the relevance of the outcome of the QIVIVE is to be made, and this may depend on the intention of its use. It can be recommended to be rather factual in describing an outcome of a QIVIVE, as done in these examples. A possible outcome of a QIVIVE can be, for a reverse dosimetry approach, at an external exposure of X milligram per kilogram body weight per day, an internal exposure is reached, steady-state unbound concentration in plasma, that corresponds to the unbound concentration in medium of in vitro bioassay Y, causing a 10% decrease in neurite outgrowth. Or, for a forward dosimetry approach, upon exposure to the health-based guidance value of chemical X, an internal exposure is reached, the maximum unbound concentration in plasma, that is 10 times lower than the unbound no-effect concentration in vitro bioassay Y. I would like to share with you a few of the many QIVIVE examples that are available in the scientific literature. First, we will look to some of the earliest proof of principle QIVIVE studies that compared obtained oral equivalent doses with points of departure or reference point derived from animal studies. We will also look to an early example applying high throughput QIVIVE that can help when prioritizing chemicals for more in-depth assessment. And finally, we will also look to one QIVIVE example that is available for DNT. The first published example on QIVIVE is from more than 25 years ago. Although in that paper the term QIVIVE was not yet used, in this study the authors assessed how in vitro effect concentration relate to in vivo effect doses. The authors studied the effects of a series of chemicals in a neuroblastoma cell line. The lowest effect concentrations from these studies were translated with PBK models to external equivalent doses, and these were compared to lowest observed effect levels from animal studies, and this showed reasonable correlations. A second important publication used a QIVIVE approach to translate in vitro effect concentrations of 5 chemicals that were obtained from the embryonic stem cell test into external equivalent doses, and compared these external equivalent doses to lowest observed effect levels obtained from developmental toxicity studies in rats, applying different exposure routes. Differences of external equivalent doses and effect levels in the animal studies were within 1 order of magnitude for 4 of the 5 chemicals tested. For the other chemical, the difference was rather large. It was 200-fold. This made the authors evaluate why the in vitro test system was expected to show higher sensitivity, thereby also showing that these QIVIVE approaches may point to interesting cases for studying differences in sensitivity between in vitro and in vivo test systems. Here you see one of the examples of applying high-throughput QIVIVE to support prioritization of chemicals for further in-depth assessment. In these papers, the authors performed QIVIVE for in vitro effect data that were obtained using high-throughput testing, and they also used high-throughput PBK modeling. The obtained oral equivalent doses are presented here as box plots, representing oral equivalent doses for all the in vitro assays considered. The authors also applied high-throughput exposure modeling. Exposure estimates are depicted here as green squares in the graph. In this example, you see 2 chemicals indicated for which the exposure estimate was within the range of oral equivalent doses for that chemical. Using this approach, such chemicals may be prioritized for further in-depth assessment, as one may expect human exposure that lead to internal concentrations that cause effects in these in vitro bioassays. The final example we look at here is for DNT. Maybe you noticed that previous examples shown used reverse dosimetry approaches. So for contextualization of the in vitro data, comparisons were made at the external exposure levels. In the example here, a forward dosimetry approach was used. As starting point, a health-based guidance value of delta metrin was applied as input for the VBK model that was developed. This external dose was translated into an estimated internal concentration, and this concentration was compared to effect concentrations reported for assays from the DNT IVB. And as such, the in vitro data were contextualized in relation to an health-based guidance value. As indicated in the overview slide on the QIVIVE approach, at the beginning of this talk, This presentation also provides some considerations of how an in vitro exposure metric can be connected to an internal in vivo exposure metric. It must be realized that there are fundamental differences in the exposure in an in vitro test system compared to the internal exposure in vivo. A typical outcome of an in vitro study is a concentration response curve, as presented on the left part of this slide. From such data, an effect concentration, such as an EC50 or a benchmark concentration, can be obtained. Such output is to be connected to an internal exposure in the in vivo situation. On the right part of this slide, you see a typical example of time-dependent concentration in plasma upon a single exposure to a chemical, leading to a certain maximal concentration, Cmax, and an area under the concentration time curve, AUC, which are important pharmacokinetic parameters to relate internal exposure to effects. Another important parameter of internal exposure, especially when considering repeated exposure, is the steady-state concentration, or CSS. Many QIVIVE cases described in the scientific literature relate a given in vitro effect concentration to a maximal concentration, or steady-state concentration, in plasma or in a tissue of interest. There is no clear right or wrong when connecting an in vitro exposure to an internal exposure in vivo. An approach often used is to relate the concentration in medium to the concentration in plasma in the PBK model. This is preferably done based on the unbound concentrations for both exposure metrics. Another approach is to link the cellular concentration in vitro to a tissue or organ concentration in the PBK model. However, this is less often applied, as information on cellular exposure in vitro is often not available. Some considerations on the appropriateness of linking the unbound concentration in vitro to the unbound concentration in plasma in vivo is provided in the following two slides. Here you see a screenshot of a figure from an interesting paper describing concepts of internal exposure to chemicals, showing the distribution of a chemical over plasma, extracellular, intracellular, and transcellular compartments of a tissue. Whereas total concentrations in these compartments differ, at equilibrium and in the absence of active transport, the unbound concentration plasma is the same as the unbound concentration in the extracellular, intracellular, and transcellular compartments. Of course, such equilibrium may often not be reached, and this assumption is not valid when specific processes like active transport or ion trapping play an important role. However, in the absence of detailed information on in vivo tissue exposure, and this is typically the case for environmental chemicals, the unbound plasma concentration is considered an adequate surrogate for unbound tissue concentration and therefore relevant to be used in the QIVIVE when linked to the unbound concentration in the medium of the in vitro test system. Depending on the molecular target of the chemical with its related molecular initiating event, a specific in vitro exposure metric may be considered more relevant than the unbound concentration. A relevant paper on related considerations of in vitro exposure is shown here. It is noted that in case there is no insight into the specific molecular target of the chemical, nor information on cellular exposure in the in vitro test system, the unbound medium concentration can be generally considered an adequate surrogate for unbound cell concentration. Gathering information on the fate of the test item in the in vitro test system, so understanding the in vitro distribution, is important to accurately determine the in vitro dose metric used for the QIVIVE. These insights might be obtained using in silico mass balance models, but they can also be obtained by quantifying the chemical in the different compartments of the in vitro test system, such as the cells and the medium. It is noted that regarding these in silico models, they are not yet tailored to the test systems of the DNT IVB. Various studies in the literature have performed QIVIVE based on nominal concentrations in vitro. However, one should be cautious in doing so, as the concentration responsible for effects may largely differ from the nominal concentration. With that, I have come to the end of this presentation. I would like to summarize some important points with these take-home messages. I hope that I've shown you that QIVIVE allows relating an in vitro exposure to an external in vivo exposure. It does so by translating an in vitro concentration to an in vivo external dose, typically applying PBPK modeling. It does not translate an in vitro response to an in vivo response. QIVIVE can be performed using both forward dosimetry and reverse dosimetry approaches. And finally, connecting the unbound plasma concentration in vivo to the unbound concentration in medium in the in vitro assay is an adequate approach, especially in the absence of specific information on tissue exposure in vivo and/or cell exposure in vitro. As indicated in the beginning of this presentation, we have 3 presentations on QIVIVE. This was the first presentation. In presentation 2, the concept of PBK modeling will be explained. Presentation 3 provides detailed considerations on using PBK modeling for the QIVIVE of DNT IVB data. On this slide, you find the references I used for this presentation. I would like to thank you very much for your attention, and please do not hesitate to contact me if you have any questions.
Welcome to the next presentation of the DNT IVB series. For today, I will dive with you in the concept of physiologically placed kinetic model for extrapolation of in vitro bioactivity data to in vivo. My name is Alicia Paini. I'm a scientific officer in the Methodology and Scientific Support Unit of the European Food Safety Authority. I would like to mention that the views expressed in this presentation are mine and do not necessarily reflect the views or policy of the European Food Safety Authority. So I see that we have 3 building blocks in the quantitative in vitro to in vivo extrapolation approach. We have the component of the in vitro concentration response. We have the PBK model that allows you to do reverse dosimetry, and we have the predicted in vivo dose response. For today, I will try to give you concepts of physiologically based kinetic models and how these can be used in this approach. For today, 2 learning objectives are concept of kinetic and how we use external versus internal dose, and basis of physiologically based kinetic model. I will give you information on how we parameterize, how we conceptualize, how we can translate model, how this can be evaluated and validated with respect to gestational models. Let's start with concept of kinetics, external versus internal dose. So exposure to chemicals comes through different matrices. These are air, soil, and water. Chemicals are then entering the body by inhalation, ingestion, and topical absorption, and are then, let's say, in the body absorbed, distributed, they can be metabolized and excreted. And then what is excreted will be coming out of the body. What is metabolized in some instance can remain in the body and can lead to adverse effect by targeting the organ and producing a toxicological effect. Kinetics is the study, as I said before, of absorption, distribution, metabolism, and excretion, also called ADME, of the chemical, and is actually what the body does to the chemical. On the other hand, dynamics is the study of the chemical, biological, and physiological effects. So what is the chemical doing to our body? Mainly going from a dose to a disease, we have several elements. First of all, as I said before, from exposure, it depends really on different information of the level, the frequency, the route, the fraction absorbed, and the duration. And this can lead to different type of toxicological effect or responses within a body. And then there is the individual response that it really is characterized by elements such as individual lifestyle, genetic makeup, the age, the gender, the health status. So all of this information are taken up together when we are assessing the risk to a chemical. It's important to know that when we try to go from an external to an internal dose and try to understand from the external dose what is the toxicological effect, we can have different type of data informing us. And here you can see a really nice description of the relationship between external dose and toxic response informed by different type of data availability. So if we only have a basic data set, we can just go directly from external dose to a toxic effect. If we would have information already about internal dose because we have a simple PBK model or pharmacokinetic model, then we can already include more specific information of this chemical. If we have information on target organ dose, we can then use a physiologically based kinetic model to understand really from external to the toxic effect. We can then go inform a more specific physiologic based kinetic model if we can include information also on metabolism. So we go to a refined mode of action of the chemical. Finally, if we will also have information about responses for instance, if we have a DNA adduct formation, then there is a repair, and we have the overall model, we really can build physiologically based kinetic models like biological based dose response modeling, so that capture the overall from external to toxic effect and all the steps in between. And this is really key information to understand how much of information we need and which type of model we can build. But for today, we will try to look into so-called physiologic-based kinetic models. When we look into the literature, physiologically-based kinetic models we have different synonyms that cover the same type of model. And here you have listed. So we have physiologically-based pharmacokinetic, biokinetic, toxicokinetic, and the more generic term kinetic only. So throughout this presentation, we will use the physiologically-based kinetic. But all of them are correct and can be used and can be searched in the literature to understand more about this type of models. For today, I would like to inform you how you can build a physiologically based kinetic model by using a tutorial that was published in 2011 by the group of Yvonne Richens, Professor Yvonne Richens, in Wageningen. And they defined the steps to characterize and build the model in 6. So you have to define your model, you have to translate the equation, you need to define your parameter, you need to solve your equation, and then you need to evaluate the model performance, and then you can make prediction. So all of these steps are described in this paper, which if you are really interested into building PBK model, I will suggest you can download and you can read. The first step in building a PBK model is really defining the conceptual model. So you need to define the exposure scenario and you need to understand the mode of action of your chemical. For this special instance, we know that we have the model needs to be a gestational model because we are looking at effects in the fetal compartment. And I have for you here defined in a very simplistic way some compartment part of this gestational model. We need the maternal plasma, a maternal liver. All other tissues are summed up in one compartment in order to make it simple. We have then defined the placenta compartment, which has a fetal plasma, fetal liver, and other fetal tissues lumped up. After this, you can, when these are all defined, you can start writing the ordinary differential equation. and you translate what have you conceptually thought into a mathematical model. And you can see here the equations that you can use. Here you have the maternal plasma, the maternal liver, the compartment of the placenta that is divided with fetal placental and fetal liver. You define the amount of chemicals in each compartment, and then you can also look at the concentration of it's the amount divided by the volume of that specific compartment. You need to include the placenta blood flow and fetal blood flow to and from the placenta. These are physiological data. So as part of the input parameter, we have information that are needed. There are 3 types of parameters: physiological, physicochemical, and biochemical. The physiological parameter are tissue volumes and blood flow of your body, of the body that you are looking at. In this case, a woman that is during her pregnancy. And key parameters are blood flow to compartment and volume of compartment. Looking at the next type of set of information, we have the so-called physicochemical parameter, and these are log P, molecular weight, that allow you to try to measure or calculate so-called partition coefficient. Usually partition coefficient are used between describing the transfer or the distribution between tissue and plasma. So here you have listed the blood flow, as we said, the volume. You need to have your concentration in the compartment, and then the tissue plasma partition coefficient. Finally, the third type of input parameter are the biochemical parameters. You need the uptake that usually is a constant rate, and then you have the metabolic parameters. In this case, the metabolic parameters are defined as hepatic clearance and or renal clearance and placental clearance. And we need to be, it's important to know that before you use this type of data, if these data are measured in vitro and are not coming from the literature in vivo or from other in silico tools, you really need to scale up your in vitro value into an in vivo value using scaling factor. Also, this is called in vitro to in vivo extrapolation, but is a scale up. And it's different to the approach that we are describing in this series of presentations. Information about how you can do in vitro to in vivo extrapolation scale up of your parameter is also reported in the OECD PBK model guidance document number 331. Just as an example, if you want to scale up, for instance, hepatic clearance that is measured with different type of matrices. You can use microsomes, you can use hepatocyte, you can use S9 fraction. You would have 3 different type of outcome. This outcome needs to be then multiplied by a scaling factor, and usually is the hepatocyte per gram liver and the liver weight. And here you have your value, that is the clearance in vivo times the clearance in vitro times your scaling factors. The value derived is your in vivo clearance that can be used as an input parameter to your model. The same is if you would have the macrosomal protein content. You need a scaling factor for the macrosomal protein content. Each species has its own protein content, so you need to check the literature for this value, but it's available in the scientific literature. So you then multiply by your in vitro clearance measured value, and you obtain your in vivo clearance, and this is used as an input parameter to the model. Finally, when you have described your compartment, you have translated them into equation, and you have the input parameters defined, so all your parameter is parameterized, you can use the software to execute solving your equations. You can usually use R, Python, MATLAB, or Berkeley Madonna, and here you have an example of a Berkeley Madonna code, which is, I believe, the most easiest way to write a code and to run a code for physiologically based kinetic models, and are especially done when you're doing a specific PBK model. When you want to use generic platforms, you can also use this type of modeling approach and you don't need to write your equation because the equation are already embedded in the software, in these platforms. And you just need the input parameters, your information of your chemical, and of course in this case you need a code within the platform on gestational model. So in this case we have TK plate. At the current moment it doesn't include a gestational model, but it will in the future, while HTTK, SIM-SIP, GastroPlus, PKSIM, Eplethem, I believe they already have embedded a gestational model. After the model is running in your software or in your platform, you need to then verify. You need to first, the verification of the mass balance is really the check that all your equations are properly written and there is not an error in your model code. If there is an error, you need to go back to the mass balance to the equation and need to try to check until the mass balance is not, it's a linear and it's doesn't give any error. The model evaluation, it's actually understanding how your model is behaving, especially with respect to also parameterizing it. So it's you can run a local and a global sensitivity analysis to see what parameters are more sensitive, and you can also try to do an uncertainty analysis to see how well is the model built. Then you have to validate the model. You validate the model. It's really the highest approach in order to gain trust into your model, which are running your simulation, and you look versus observed in vivo data that are available in the literature or you have available, and see how good they fit one to the other. So if they are within the same range, the model is predicting, is simulating in a good way. And usually the WHO defines a factor of 2 to be the best for model validation. However, it's also criticized by the modeler community that this is too conservative as an approach. This is just showing you that the PBK model simulation are the lines and are in this case checked against in vivo experimental data available for human individual. These are actually information on a caffeine, so caffeine is quite easy to have, and you have information on blood concentration. So they were able to evaluate the model versus in vivo data. In this case, actually, the model is actually fitted. You can see that in vivo are the dots, and the model really describes the in vivo dose response. So the model is fitted, and this you usually do when you want to predict one input parameter in order to inform your model, and you're actually calibrating your model to your in vivo data or fitting the model. So for today, I hope that I gave you a little bit of introduction about what are kinetics, what is exposure, and how we go from external to an internal dose, what are the key elements that can influence your response, and also what are the information data that are needed in order to decide of what type of model you can use. And then going into the PBK modeling, I gave you a flavor of what are the information of a PBK model needed to build a model. And thank you for attention. These are just some references that I would like you, if you would like to dive deep into this type of topic, and I'll be happy to answer any question also offline.
Hello everyone. Welcome to the DNT in vitro battery training webinar series. This session is part 3 of our course Quantitative in vitro to in vivo extrapolation. Today, we will be diving into the unique considerations involved in kinetic modeling. My name is Cecilia Tan from the U.S. Environmental Protection Agency in the Office of Pesticide Programs. Before we begin, I'd like to share a brief disclaimer The view I'm expressing today are my own and do not necessarily represent the views or policy of the US EPA. Any mention of trade names, products, or services is not an endorsement by the US government or the EPA. Let's start with a quick review of quantitative in vitro to in vivo extrapolation. This process involves correlating a selected in vitro concentration of interest to an in vivo internal concentration, such as the average plasma concentration. We then extrapolate this internal concentration to an external dose using quantitative tools, most commonly a physiologically based kinetic or PBK model. The estimated external dose can then be compared to an external concentration of interest, such as typical human exposure levels. In this scenario, the exposure and corresponding biological responses occur in the same individual. When considering DNT, except in cases where an infant is directly exposed to a chemical, initial exposure often occurs in the mother. The DNT effects might then occur in the fetus or nursing infant through secondary exposure. Also, the target tissue for DNT effects is the brain. So if the concentration in the fetal brain is the internal dose metric, we would theoretically need a gestational PBK model. This model would track the chemical entering the mother, distributing to maternal tissues, metabolizing and being excreted, crossing the placenta, metabolized, excreted, and distributed within the fetus. Similarly, to predict chemical concentration in the nursing infant's brain, a lactational model is likely required. This model would predict the chemical entering the mother, being distributed to tissues, metabolized and excreted, entering into breast milk and then being transferred to the infant through lactation. However, depending on the purpose of the analysis, such precise predictions may not be necessary. More importantly, we often do not have sufficient data needed to accurately parameterize these models and predict brain concentrations. So next, we will introduce a tiered strategy for kinetic modeling. Modeling strategy. When we talked about a tiered strategy, we are talking about a method that applies increasingly complex and precise approaches only when necessary. Higher tier approaches are backed by more data or knowledge, which means they should carry less uncertainty. On the other hand, lower tier approaches are simpler, faster, and often more conservative. It is important to clearly justify why we might move or choose not to move to a higher tier. Same principles apply to tiered PBK modeling. We should only add complexity to a PBK model if it is necessary for specific purposes and supported by reliable data. A higher tier model should deliver a more precise result or reduce uncertainty compared to a lower tier model, and not just by making a model more complex. For example, if a critical inputs like placental transfer or fetal clearance are highly uncertain, using a gestational model to predict fetal plasma concentrations might not be better than a simpler, non-pregnant model that predicts maternal concentrations, which can often be validated much more easily. For DNT, The most direct dose metric is unbound concentration of chemical that crosses the blood-brain barrier and reaches the developing brain during crucial developmental windows. However, measuring chemical concentration in the brain is not feasible in humans, and it is quite challenging even in animals. This lack of empirical data makes it challenging to accurately predict the free chemical concentration in the brain. While PBK models can often predict tissue concentrations using tissue to plasma partition coefficients, this approach might overestimate brain exposure because it does not fully account for the blood-brain barrier. Also, interspecies extrapolation of brain partitioning is tricky when a chemical is a substrate of transporters in the blood-brain barrier. The blood-brain barrier is a semi-permeable and selective boundary that separates the central nervous system from the bloodstream. It is both a physical and a metabolic barrier. Because of its protective nature, it is estimated that most small molecule drugs and all large molecules cannot cross the blood-brain barrier. For example, only 5% of more than 7,000 drugs in the comprehensive medicinal chemistry database are marked blood-brain barrier permeable. For developing brain, blood-brain barrier becomes functional soon after its formation to provide essential protection during early embryonic development and continues to mature through gestation. For example, tight junction proteins are present in the developing human brain as early as 12 weeks of gestation. While there are both in silico and in vitro methods available to predict blood-brain barrier permeability, they often do not provide the quantitative values needed to parameterize a PBK model. Moving on to fetal exposure, which requires the consideration of how chemicals transfer across the placenta. This transfer can happen in two main ways: passive diffusion or through various transporters. Passive diffusion is bidirectional, meaning it occurs both from the mother to the fetus and vice versa. It is governed by the chemical's physicochemical properties, such as lipophilicity, polarity, and molecular weight. But that's not all. Other factors like plasma protein binding and clearance mechanisms in both the mothers and fetus, which can all change throughout gestation, also play a role in maintaining the equilibrium between maternal and fetal concentrations. There are limited data available that quantitatively link these physicochemical properties and biological factors to placental transfer. Plus, the rapid physiological changes happening in both the mother and the fetus during gestation add another layer of complexity, making it quite challenging to accurately predict a chemical's ability to transfer across the placenta. Limited data on placental transfer of environmental chemicals. A 2021 paper reviewed 32 studies that examined placental perfusion of environmental chemicals. Here, they grouped the chemicals according to their transfer rates reported from ex vivo placental perfusion studies. Fast transfer has a fetal-maternal ratio greater than 0.7 and fetal transfer greater than 35%. Medium transfer with a FM ratio between 0.4 and 0.7, and fetal transfer between 20 and 35%. limited transfer with a FM ratio between 0.3 and 0.4, and fetal transfer between 1 and 20%. And slow transfer with an FM ratio less than 0.03 and fetal transfer less than 1%. They found that the placental transfer of environmental chemicals is highly diverse. Parabens and acrylamide transfer faster, similar to passive diffusion. Others like BPA, cadmium, perfluorinated chemicals have slower transfer rates due to factors such as protein binding, being substrates of transporters, or partially metabolized by the placenta. Other substances like TCDD seem not to be transferred at all during the 4 to 6 hours of placental perfusion. Let's talk about gestational and lactational PBK modeling. Though there are thousands of published PBK models available in the literature, there aren't many gestational and lactational models because of numerous knowledge gaps that limit the development of these models. A study from 2012 identified 43 published gestational models and found that most of these models were contributed by 5 research groups. More recently, a 2023 review paper found 40 models based on their search criteria, with 16 on environmental chemicals and 24 on drugs. When it comes to describing the fetal component in these models, there are generally 4 approaches. The simplest approach adds a placental fetal compartment directly to the PBK model for the mother. The second approach treats the fetus as a separate compartment that connects to the models of the mother through the placenta. The third approach incorporates amniotic fluid as an additional component because chemical concentration were likely measured in amniotic fluid for these chemicals. The most complex approach involves creating 2 separate PBK models, one for the mother and one for the fetus, which are connected through the placenta. Let's talk about why developing gestational models is challenging. Pregnancy brings about significant physiological changes that can dramatically impact the kinetics of chemicals in the body. For example, studies have shown that some CYP and UGT enzyme activities and renal transporter activity can change during pregnancy. These changes can either increase or decrease the clearance of a chemical, and often clearance data are not available. Also, we often do not have data on other critical factors, such as transplacental transfer, placental metabolism, and the changes in kinetics related to fetal development. Even when concentration data are collected at birth, these data may not accurately reflect fetal exposure during different stages of development. Finally, for chemicals that cross the placenta through passive diffusion, there is an important principle to keep in mind. Under steady-state conditions, fetal concentrations should not exceed maternal concentrations. So maternal concentration should be used as a surrogate for fetal concentration. Now, let us shift our focus to lactational modeling. When it comes to drug transfer into breast milk, most of it occurs through passive diffusion and is directly related to maternal plasma concentration. However, There are limited data available on how environmental chemicals transfer into milk. A key measure in this context is the milk-to-plasma ratio, which indicates how readily a chemical transfers into milk. This ratio is relatively straightforward to measure, and there are predictive models available to estimate it. Typically, chemicals with higher milk-to-plasma ratio are lipophilic, have a low molecular weight, and have low plasma protein binding. However, the milk-to-plasma ratio alone is not sufficient to evaluate infant exposure. We also need to consider factors such as maternal and infant clearance rate and other variables that can influence infant exposure. Now let us discuss some of the challenges in developing lactational PBK models. We did a literature search and found fewer than 20 lactational models. One of the main challenges is the physiological changes that occur during lactation in both mothers and infants. For example, changes in body weight and fat composition can impact chemical concentrations in milk over time. Additionally, chemical concentrations in milk are influenced by both active and passive transport mechanisms, as well as changes in milk composition over time. Factors like the time since delivery and milk removal by the infant during breastfeeding can play a significant role. Also, determining the infant dose can be challenging, as it depends on feeding parameters such as the volume of milk consumed and the frequency of feedings. These factors can vary greatly between individuals and over time. Let us revisit the concept of tiered modeling. It is important to emphasize a key principle. A model should be as complex as necessary to achieve its intended purpose, but no more. Adding unnecessary complexity, especially when reliable data or biological understanding is lacking, can lead to unreliable predictions and create a false sense of confidence. Higher tiers, such as the gestational and lactational models, are not inherently superior or necessary for all applications. These models, as we mentioned before, required a lot more data to ensure reliable predictions. When data are limited, Tier 0 kinetic models that predict maternal plasma concentration or juvenile plasma concentration from direct exposure, or Tier 1 PBK models are often the better choice. These models have fewer parameters and are generally sufficient for predicting plasma concentrations in exposed mothers. This can serve as a reasonable surrogate plasma or brain concentrations in the fetus or infants. To wrap up, I've provided some references related to this presentation in the next 2 slides. If you have any questions or need further clarification, please feel free to reach out to me via email. Thank you.